It's my pleasure to introduce today's speaker. Let me tell you a little bit about Dr. Fojo. He received an MD and a PhD in biochemistry from the University of Miami. And from 1978 to 81, he trained in internal medicine at Barnes Hospital, Wash U School of Medicine, and was the chief resident there. And in 1982, he transferred to the medical oncology program at the National Cancer Institute. And shortly thereafter became a senior investigator in the medicine branch of the NCI, a position that he held until fairly recently, August 2015, when he moved to Columbia University and the James J. Peters VA Medical Center. For nearly a decade, he was also director of the Medical Oncology Fellowship Program at the NCI, one of the largest in the United States. His research interests have included drug resistance in general, with an emphasis on multi-drug resistance and mechanisms of action and resistance of microtubule targeting agents. He has also published extensively on TP53 and its intracellular trafficking, and this line of research investigation evolved to studies of DNA damage and how that might be mitigated, and the role of the microtubule system in the trafficking of DNA damage repair proteins. He came to Columbia to expand his research efforts on endocrine and neuroendocrine tumors, hence the invitation to speak with us today, with an emphasis on developing therapies for these unique but often difficult to treat cancers. And during his entire career, he has conducted clinical trials that derive from his laboratory interests with an emphasis on translational research. So a true physician scientist, going from bench to bedside, back to bench and back to bedside. His clinical interests include adrenal cortical cancers, neuroendocrine tumors, including Theochromocytomas, paragangliomas, and the development of microtubule targeting agents and histone deacetylase inhibitors. He also has an interest, as I said, in clinical trials endpoints, the conducting of clinical trials in oncology, and the cost of cancer therapeutics. I got to know Dr. Fojo in sort of an unusual way. We both have an interest in a rare disease, adrenal cortical cancer, and there are not a lot of people, particularly in the tri-state area, who have this interest. And we found that we were sharing patients. So my patients would come in and they would say, Dr. Fojo said, and I'm thinking, I got to look up who this Dr. Fojo is. And so I picked up a phone and I called him and we had a little Zoom meeting and we learned of our shared interests. And I thought, what a wonderful opportunity to have him come and speak with us. So I am so pleased that you accepted the invitation and I welcome you. Thank you for coming.
Thank you, Alice. That was the nicest introduction I've heard ever, really. Thank you. You're very kind. And I appreciate the invitation. And so I'm going to start by sharing my screen. We tried this a second ago and it seemed to work. There we go. Can you all see it?
Yes. And then can you just try expanding it if the screen share doesn't work?
There we go. That's expanded. And you saw me move it, right?
Yes. Mm-hmm.
Okay. Yeah. So I'm going to tell you a little bit about endocrine tumors in general, and then as a lead into adrenal cortical cancer. And I know that many of you have a clinical interest. I'm going to show you some basic data just because that's what I do for a living. But you'll see that it all arises from taking care of patients and just thinking about patients and how to do things better for them. And so I think that even if your interests are clinical, you'll understand why we're doing what we're doing at a basic science level. And I think it'll inform you as well. So I take care, as Alice said, of ACC, Theochromocytomas and paragangliomas, and then sure, why not, thyroid neoplasms. And so those are actually moving in very interesting ways, but I won't be talking about those today. So what I want to tell you is for the last 10 years, if not more, for the last 15 years, it's driven me crazy that patients come in, they've had their tumor harvested, they've had it analyzed, usually by Foundation One, and it's told them what the mutations are that they have in their tumors. And they come in, they used to when they would come in, now on Zoom you see it, but they would come in with their profile and say, here, doctor, basically, this is me, this is my tumor, figure out how you're going to cure me, which drove me crazy because I knew I couldn't cure them. And I was really annoyed that someone had led them to believe, whether it was a physician or whether it was the internet, that this was the key to curing cancer. And yeah, in cancer, we've done well. We actually have some diseases, for example, lung cancer with EGFR mutations, where we have tons of very sophisticated targeted therapies that target the epidermal growth factor receptor and that work really, really well. Or even in lung cancer, the ALK, anaplastic lymphoma kinase cancer, go figure that it would be important in lung cancer. And we've got several drugs that target that and do that quite successfully. But the idea that you're going to have a cancer, you're going to go get a molecular analysis, and then some physician is going to look at that and say, aha, I know how I'm going to cure you, is actually irresponsible, has never been validated. And when they show you data that says, look, we validated it, all that they have really done is do an analysis where they fill it up with lung cancer patients with EGFR, ALK mutations, and so forth, and it makes the data look good. But fortunately, along came immunotherapy. And I say fortunately because now everybody, instead of bringing their molecular analysis, walks in the door and wants to know, can you jazz up my immune system to delete my cancer? And of course, we can't do that either in adrenal cortical cancer, and I'll come to that eventually. But all of this I've been thinking about for a long time. Alice said how I do have an interest in clinical trials. I have an interest in the cost of cancer therapies, and I hate to see someone get hundreds of thousands of dollars of some therapy and go heavily into debt when the therapy wasn't going to work. And yeah, precision oncology, its origins were noble. The optimism is reflecting a specialty, i.e. oncology, where all of us are optimists and where things oftentimes don't work very well, and we're optimistic we might do better. And its potential is good in certain situations. But as I say, not the adrenal cancer patient who has their molecular analysis and then comes to see you. This, for example, in Theochromocytomas and paragangliomas, in Cell, Cancer Cell, all of these journals, they'll publish any number of analyses that really have no relevance to real life and no relevance to patients. But to me, this is a really interesting one. They looked at the molecular characterization of pheochromocytomas and paragangliomas, extensively did it. And what do we have? That pathogenic germline mutations occurred in 8 pheochromocytoma paraganglioma susceptibility genes. So, and to me, this remains a puzzle. Do you know how rare pheochromocytomas and paragangliomas are, and especially malignant pheochromocytomas and paragangliomas? And that already we think there are 8 genes that predispose to that? I'm sorry, I have a hard time wrapping my mind around that. If there are so many genes that can lead to this, why don't we have an epidemic of pheos and paras? Instead of what usually happens, that everybody hears about it in medical school. And then you say, when I grow up and I'm a real doctor, the day that pheochromocytoma walks into my office with the classical symptoms, palpitations, flushing, high blood pressure, I'm going to nail that diagnosis. And then they go 10 years, they never see one. And on the 11th year, when they finally show up, they miss the diagnosis. And they come to see me eventually. And then you say it was screaming pheochromocytoma, but they didn't get it. Why? Because it's such a rare disease. So at this moment, I'm still conflicted as to how there can be 8 genes, and it's probably going to rise to even more. Actually, there's probably a 9th one already, that can lead to the development of pheochromocytoma, paraganglioma, and we're not in the middle of an epidemic of pheo and para. So with all of that in mind and putting molecular analysis in perspective, and I'll show you our own data on molecular analysis of adrenal cortical cancer, what you end up thinking is that these tumors, gosh darn it, they're really unique. We can probably develop some very specific therapies without messing with that molecular analysis. So I think you all know this, rare cancer, 1 per million, it's about right. And that's remained very constant for decades. Surgery remains the only curative modality. And I, as a medical oncologist who treats with chemotherapy, I'm acutely aware of that. And I make sure that I'm surrounded by only the best surgeons. And my job, I tell patients, is to give you chemotherapy to kind of set you up to then find you the right surgeon to try to cure you. 67% of patients who undergo surgery suffer a relapse. This is probably my most difficult conversation. Patients come after surgery and they think, I'm just going to see the medical oncologist. And you have to tell them, oh, by the way, that great surgeon you had probably hasn't cured you. We're going to have to follow you really carefully. And it always, not always, in the overwhelming majority of cases, it takes patients by surprise. And then local relapse is actually a relapse on the peritoneal surface. And you'll see why I'm emphasizing that later on. So the folks out in Germany and in most of Europe, they said, we're going to come up with a European network study of adrenal tumors, the NSAT, and we're going to do a classification of it. And they decided they would have an NSAT 1, 2, 3, and 4 classification. Instead of staging and be stage 1, 2, 3, and 4, let's make our own classification. And when you look at this, you say, what's he talking about? You know, why is this such a bad disease? Look how well people can do. I mean, look at those NSAT 1, 80% of them are alive 10 years later. What's going on here? The problem is that hardly anybody is in NSAT 1, very few are in NSAT 2, not that many are NSAT 3, and the majority of patients are NSAT 4. Now, what is NSAT 4? It's anybody who has metastatic disease. And the majority of patients, meaning more than 50%, have metastases at the time they present. And then there's another 20 to 30% that had them, you just didn't see them. So metastatic disease develops in a majority of patients with adrenal cortical cancer, and therein lies the challenge. But what I will tell you is that metastatic disease in adrenal cortical cancer is not a life sentence. And I can tell you that because practically everyone that I've treated in my life with adrenal cortical cancer had metastatic disease when they presented to me. 98% of them did. That's why they came to see a chemotherapy doctor, okay? And I have an increasing number of patients, now, you know, probably over 50 in my career, who years later are still alive with no disease recurrence and are probably cured. So metastatic disease is not equivalent to a life sentence. So let me just go on. Okay, so then I talked to you about those targeted therapies. In ACC, they have been a major disappointment. There's been any number of trials. This sort of summarizes the largest. Look at the time for PFS. So PFS is an oncology term that means progression-free survival. And it means you have to live, and the majority of patients do live, and your disease cannot progress. And what do we mean by progress? It means that the one-dimensional measurement of your disease cannot increase by 20% above your starting point, or cannot increase by 20% above your nadir. So if you have a response and the quantity of tumor goes down, if it increases by 20% from that lowest value, you have progressed, okay? Or if you don't have any shrinkage, by the time it increases by 20% over the starting value, you have progressed. Look how long it takes for that to happen with metastatic adrenal cortical cancer. Less than 3 months, less than 12 weeks or 3 months, 59 days, less than 8 weeks, less than 8 weeks, less than 3 months, 6 weeks, 5.48 months, 44 days, and less than 8 weeks. So that's not very successful, is it? So that these targeted therapies have over and over and over again failed. And I'll show you why in a second. So one of the greatest disappointments was IGF. There was a lot of literature that said IGF, the insulin-like growth factor, signaling through several of the IGF receptors was very, very, very important in adrenal cortical cancer. This is one study, this is one example of the many things that are important in animal models that are rated to be important, in cell culture that is rated to be important, but when it comes to the patient, they really aren't. It eventually led to Lincitinim, a drug that has never been approved, which was an IGF-1 inhibitor, okay? An inhibitor actually of the IGF-1 receptor, okay? An orally administered drug. It was given to patients with adrenal cortical cancer. And as you can see here, the interpretation, Lincitinim did not increase overall survival, and so cannot be recommended as treatment for this general patient population. This is what happened to survival. The blue is the placebo, the red is the Lincitinim. This is a Kaplan-Meier looking at overall survival over time. This, by the way, here is 1 year. So you can see that half of these patients had died by 1 year. If you go back and you look at the NSAT, I should have shown you that at 1 year, those NSAT 4, which are stage 4, 50% of them are dead. Okay, this is a bad disease once you have metastasis. So what about this IGF-1 expression, IGF-2 expression that was so important? Really, when we finally got all of this data into, areas where you could analyze it, large data sets that are available, this is IGF-2. This is IGF-2 in the blue. That's in the normal adrenal. In adrenal cortical cancer, that's this pink color. You can see 2 and 4 here. It's about 2.2 and about 3.6. So 1.42 logs, except that the base here is 2. So it's less than 4 times the expression in adrenal tumors than it is in normal adrenal. Not a whole lot of difference. 3.6 divided by 4.2, about 1.5-fold higher, not even. Now, when you got all of this data, you realize that most of the data that was being published was actually biased and skewed. We wouldn't get very excited about something that's 1.5-fold higher in a tumor, and we never should have. So then we got to molecular characterization of adrenal cancers, just as I showed you molecular characterization of Theochromocytomas. So for all of you who are endocrinologists, who are oncologists, who are whatever you specialize in, you can go and read these sort of papers and understand them. And then say, that's interesting. And then walk away and say, but it has no relevance to the patient I'm going to see in clinic tomorrow. Okay. And why is that? I'm going to show you. So the original data was published by Acth. They basically scooped us, but it's fine. Acth was a European group that looked at patients, and 58% of them had recurrent disease, 35% had died, but 42% of them were original presentation adrenocortical cancer. This had limited information for me because at the time I was at the NCI, and not 98%, 100% of the patients that I treated had recurred. They all presented to see me because they had recurrent disease and they needed a medical oncologist to give them something in their veins, i.e. chemotherapy to treat them, right? So here's a secret that I've kept all my life. I actually, until I came to Columbia, had hardly seen but just 2 or 3 patients among hundreds that I had seen that had de novo disease. I really didn't know anything about de novo adrenal cortical cancer. I knew about those who had de novo who had failed and then came to see me, okay? But it turns out that that's the majority of patients. So what did this tell us? Well, one of the first things that it told us was about the mutational load in adrenal cortical cancer. And then, so that has become very important in the management of oncology patients. We believe that if you have a high mutational burden, and there's a term TMB, tumor mutational burden, that if you have a lot of that, immunotherapy is more likely to work. And why is that? Because the immune system is to say, what is that strange thing that's sitting there in my left adrenal bed? It will recognize it, or is not metastasized to my lung. It will recognize it as something foreign because it's so heavily mutated that on the surface, there's a lot of proteins that have been mutated and look different. So when you look at adrenal cortical cancer and compare it, for example, to melanoma, which is the poster child for mutations, okay? And you compare it to bladder cancer, which also responds to mutation, you see that adrenal cortical cancer isn't so bad. But you know what? It has less than colorectal cancer, and immunotherapy has failed in a colorectal cancer unless you have Lynch syndrome, a disease that leads to a very high tumor mutational burden. And it has failed in pancreatic cancer, and it's the same in adrenal cancer and pancreatic cancer. So this mutational burden ends up not meaning all that much. And it means even less when you realize that the majority of patients with adrenal cortical cancer are in a minority, maybe about 20 to 25% cushingoid, and another 25 to 30% are pushing out steroids that are immunosuppressive. So these are patients that have a very immunosuppressive environment in their bodies and in their tumor, and the likelihood that they'll respond to immunotherapy is very, very low. So I haven't gotten around yet to preparing this patient for write-up, but I had a really interesting case of a young woman recently who presented with adrenal cortical cancer. And as she was being treated for her adrenal cortical cancer, she started to bleed per rectum. So I have seen just a handful of patients metastasize to their GI tract with adrenal cortical cancer. But she was bleeding per rectum, and they did colonoscopy, and they came back and you told her, you've got colorectal cancer. So she had colorectal cancer and she had adrenal cortical cancer. And they said, well, you know, we do surgery for this, and it was going to be it was rectal cancer. Actually, it was going to be very debilitating surgery. And she said, no, I don't want that. So then a few weeks later, they come back and say, you know what? You have Lynch syndrome. And she said, what? Lynch syndrome. I said, wow, what is that? He said, well, what it's done is it's caused your tumor to have a lot of mutations. Maybe immunotherapy will work. And she said, fine, let's do it. In the meantime, she said, called her mom and said, Mom, you know, you remember you had colorectal cancer a few years ago? They told me I have Lynch syndrome. Mom went and got tested. Mom had Lynch syndrome. So here was a woman who had colorectal cancer and adrenal cortical cancer in a germline background of Lynch syndrome. And we think that Lynch syndrome can predispose to adrenal cortical cancer. There's more than a handful of cases that have been reported with that. And actually, Gary Hammer at Michigan gets credit for being the first to have suggested that. And he was right. I was skeptical when he first suggested it, but he was right. And so she had a very high tumor mutational burden in her colorectal cancer. And we managed by hook and crook to get her original cancer biopsy from Mississippi. And she had a very high tumor mutational burden in her adrenal cortical cancer. She started immunotherapy. She had a complete response to her colorectal cancer. 2 years later, she was still disease-free. While she got the immunotherapy, the tumor mutational burden, heavy loaded adrenal cortical cancer grew and grew and grew and grew. And the reason is because in that tumor, the environment was full of steroids and there wasn't a single lymphocyte that was going to survive. So you could send all the lymphocytes you wanted to there, and what you were sending them to was basically suicide. So it's important when you think about adrenal cortical cancer to not only their tumor mutational burden, but to manage aggressively their hormone production. So we did this. So like I told you, the Acth paper had a lot of patients that didn't have metastatic disease. And I said, I really want to know about patients with metastatic adrenal cortical cancer. And these are 43 patients that all had metastatic adrenal cortical cancer, all had had metastasectomies at the NCI. So we had a lot of tumor on them. And what we did was we did an analysis of their tumors. The Acth paper is shown below. Our data is above. This is just looking at frequency of copy gains and losses in 17 ACC tumors, where we did also molecular analysis to look at their their copy gains or losses at hormone level. You can see that the Acth tumors, which were half de novo tumors, and our tumors that were all metastatic, look identical. When we looked at mutations, we found very similar. Acth reported 16% to have CTNNB1 mutations, and this is beta-catenin mutations, and 16% to have TP53 mutations. We had the same 16% CTNNB1, but we had 27% with P53. And the reason for that is because P53 makes tumors bad. And so when you get the patients who have recurred and have metastatic disease, you've enriched for those that originally had a TP53 mutation. That's why our patients had a higher level. But other than that, Acth had nothing that was meaningful, and we had nothing that was meaningful. And what we had mostly, which is what Hassie has, was missense mutations. But there were missense mutations in all sorts of things. So my wife loves chromatin, loves epigenetic therapies, loves histone deacetylase inhibitors. So of course we looked at alterations in chromatin remodeling genes. They're all over the place. But are they important? I don't think so. She hopes so, but I don't think so. And then when we looked at these adrenal tumors, and we had done deep sequencing on all of them, and they had a lot of mutations, actually, they didn't. They didn't have a lot of mutations. What you see here is cancer average mutations, ACC average mutations. And in this case, we not only took our data, but we took the data from ASCI and another TCGA data set, the Cancer Genome Atlas data set that was there. And we said, how do the mutations in adrenal cancer compare to mutations in other cancers? And in fact, all of these genes that are mutated in adrenal cortical cancer, the frequency that you find for those mutations now across over 150 patients with adrenal cortical cancer is far less than it is for the average normal other tumor, not normal, the average other tumor. So ACCs have a lot of mutations, but they actually don't have any more than do other tumors, with the exceptions of two things, CTT-NNB1, beta-catenin, and this HGC 6.3 that I have not the clue as to what it is, and actually have not been incentivized to look at what it is, because I don't believe it's going to explain adrenal cortical cancer. It's present in only about 10% of adrenal tumors, but rarely found in other cancers. There is also one thing which is interesting and most people overlook. These are mutations in genes that turn out to be big genes, okay? If you look at all of the genes, the average length of a transcript is 1,070 base pairs. If you look at the COSMIC database, and the COSMIC database are putative cancer genes, genes that have been described and are thought to be and are implicated in either the causation of cancer, the maintenance of cancer, or the promotion of an existing cancer. The average COSMIC gene is already twice as big, 1920. The average gene mutated in ACC is 4,460 base pairs long. So in fact, most of these mutations are just occurring because these are large genes, and the larger the gene, the more likely you are to mutate it, just randomly. So basically, the majority of the mutations in adrenal cancer are of no consequence and no significance. I seem to have frozen. There we go, let's see. It's not responding. Let me see if I can get it to respond. Okay, I may have to do it that way now. Okay, so, and then to show you that it matters where you get your tissue samples, this is the TCGA data, and the TCGA data had almost exclusively patients at the time of initial presentation. If you look at those that were TP53 mutant and those whose tumors were TP53 wild type and mutant, the wild type in black fare incredibly better. So if you have an adrenal tumor taken out, you want to have it be a wild type tumor. These are Kaplan-Meier's of those who had wild type and those who had mutant. You can see the mutant dying quickly. Within 2,000 days, they nearly have all died. Here, we have our own data, and we looked at those that had T53 wild type and T53 mutant. Now, I told you we enriched for mutant because those are better cancers, but we've also enriched for bad cancers overall. Those who have metastatic disease, recurrent disease, and came to see me had bad cancers. And now it didn't matter whether they were wild type or mutant for P53, they all did equally bad. Why? Because we selected for tumors that are not only depending on mutant P53 to be bad, they're depending on a bunch of other genes to be bad, and bad cancers just do poorly. Finally, we did a lot of expression analysis, which had been done in the past. and it gets really complicated. These are normal adrenals here on the left, the first 5. And all that I'm showing you this for is there actually are some tumors that are normal adrenal-like. As you can see, these genes here that are expressed in red hot levels in these tumors are normal adrenal genes that aren't present, because you can see by the green, in the overwhelming majority of adrenal cancers. And these genes are highly expressed in some tumors that, remember, even when metastatic, that they were at one point a normal adrenal cell, okay? The other thing to point out to you here, don't be thinking, oh, Tito, that's probably some normal adrenal contaminating your tumor. No, these came to see me when they had metastatic disease. So the overwhelming majority of these are lung metastases that have been harvested at the time of surgery. There was no normal adrenal there. These are just tumors that even after metastatic, remember that their cell of origin was the normal adrenal. So the conclusions from the sequencing data is the likelihood of a significant therapeutic advance emerging from sequencing data is very low. And no one should be mining adrenal cortical cancer data for mutations to develop a meaningful therapy. It's just not going to happen. So I'm obviously peppering this presentation with my strong bias, but you didn't want to listen to me to tell you what everybody else thinks. You wanted to listen to me to tell you what I think. So we must look elsewhere for therapeutic ideas. And what I would say is adrenocortical cancers, in fact, all endocrine cancers are actually very unique. So why don't we do that? So how do we develop targeted therapies for ACC that are truly targeted? So what is unique about ACC? So not long ago, actually just 30 years ago, one of my first patients, it was actually about 1996 or so, one of the first patients came to see me at the NCI, had a diagnosis of testicular cancer. He had developed a testicular mass and he metastasized. And then the fellow taking care of him was someone I had trained at the NCI. And he sent me the history and I said, boy, this is interesting. I said, send me the tissue and I'll have it checked out. And it came and it got in the hands of a pathologist by the name of Maria Marino, who was a really good pathologist and still is. And she called me up and she said, Tito, that tissue that Mark Feason sent you, that's adrenocortical cancer. I said, no, come on, Maria. This began as a testicular mass. This is testicular. No, it's adrenocortical cancer. And she said, you know that in the adrenal, in the testes, there are adrenal rests. And what this gentleman did was develop an adrenocortical cancer in his adrenal rest in his testicle. So I didn't believe Maria. And indeed, you can see here adrenal rest in a normal testicle. They live there. But I didn't believe Maria. And I said, I'm going to look at this molecularly. So I said, what's unique about adrenal cancers? I said, well, one thing that's unique is 11 beta hydroxylase. And the other thing that's unique is ACTH receptor. So in the lab, I got a bunch of normal adrenals. You know, this is when we used to do this by PCR and we didn't. And I documented that in the normal adrenal, you could easily detect 11 beta hydroxylase, did 24 normal tissues, and only the ovary of the testes had a little bit of 11 beta hydroxylase, but only about 1/100th that in the normal adrenal. So I said, okay, that's probably a good marker of adrenal origin and not of testicular origin. So then I got 2 cell lines, a colon cancer and a breast cancer that weren't adrenal origin, and they neither expressed the ACTH receptor, not 11 beta hydroxylase. A bunch of normal adrenals expressed them both. I got 2 adrenocortical cancers that I knew were adrenocortical cancer. They expressed them both. And this patient that I had doubted Maria Marino's diagnosis of adrenocortical cancer that had this testicular mass, wow, look at that. Expresses the ACTH receptor and 11 beta hydroxylase. I went and profusely apologized to Maria and never doubted her again. And it's served me very, very well. So later on, this patient developed metastatic disease, and that's why he had come to me. We actually treated him with chemotherapy, and he had a complete response to chemotherapy. And about a year later, recurred, and he came back, and he said, Doc, I got a recurrence. And he said, I don't know that I want any more chemotherapy, Doc. And His doctor, Mark Feason, was out in the middle of Idaho, and he said, I can find somebody, Tito, to take out his pituitary. Why don't we do that? And I said, sure, why not? He's got ACTH receptor on his surface. Why don't we do that? And at the time that we took out his pituitary, he had this tumor in the lung and this tumor in the lung and several tumors in his abdomen. We removed the pituitary in July of 95, okay? By October of 95, that's all we had done. We removed his pituitary. He had had a complete remission of his lung disease, totally disappeared. And the abdominal disease totally went away. His ACTH was undetectable. It had gone from a level in the 1,000+ level to undetectable. What I should tell you that I didn't tell you, this gentleman had congenital adrenal hyperplasia. And you know how they know more about themselves than you do? And besides, he liked that tan colored on his skin. So he walked around all the time, self-managing the adrenal replacement. He was tanned as could be, and he had an ACTH level of 1,200. We took away his pituitary, his ACTH totally normalized, and he went into a complete remission. This was the first demonstration that ACTH for adrenal cortical cancer is actually a mitogen. And I did a lot of studies in the lab where I documented this. I actually sent this to the New England Journal of Medicine in the late 1990s, thinking it was an interesting case. And they said, no, we're not interested in it. And I never published it. And I should have. And maybe someday I will. So a hypophyseectomy removes ACTH. We also developed some anti-ACTH antibodies that we have never carried further, and that's for lack of support. Do adrenal tumors express the ACTH receptor? Absolutely. Here on the right, you see some normal adrenals, and that's expression of the ACTH receptor in the normal adrenals. These are ACTH tumors. The overwhelming majority of them express the ACTH receptor. This here in red is the only bona fide adrenal cortical cancer cell line that exists, and it has very low levels. And I show you this because when I take care of patients with adrenal cortical cancer, I'm always reminded of that patient. Now, you all do this as well. You treat them with Mitotane. Do you ever check the ACTH level? I've stopped doing it because I hate to be scared. They invariably go high. We can't emulate the normal adrenal function by giving hydrocortisone in the morning and in the afternoon. They invariably have high levels of ACTH. Maybe we should give them BID or QD prednisone and have a longer lasting impact on ACTH secretion, and that would happen. But not long after you start anybody on Mitotane, even on prednisone, you just can't emulate the normal pituitary. The ACTH level rises. And I'm always reminded of that patient. And I'm always reminded of the fact that every one of these tumors, or nearly most of them, have the ACTH receptor. And now I've driven their ACTH levels up, and I'm worried about that. And I'm thinking what I've done is induce a mitogen. And you know, it's not uncommon to see Mitotane work initially, and about 6 months into Mitotane, you begin to see recurrences. And I always worry, yep, that's about the time I finally knocked off the adrenals, ACTH rose, and is that what's driving things? Maybe. So, but having the ACTH receptor is unique to adrenal tumors and to the adrenal gland. Maybe we can exploit that. So we have done that. When I was back at the NCI, I convinced, after 20 years, Ira Paston, my mentor, to link Pseudomonas exotoxin to ACTH. And we linked this, created a construct that basically made ACTH with the Pseudomonas exotoxin toxin link behind it. And then what we envisioned was that the ACTH portion would bind to the ACTH receptor, here as MC2R, and it would have attached to it the Pseudomonas endotoxin receptor. And we know that when ACTH binds to MC2R, it's internalized, goes to endosomes. We figured we would release Pseudomonas exotoxin and that would be toxic. And remember, the majority of adrenal cancers have high levels of the ACTH receptor. And then the problem was that we needed it to have MC2R and MRAP because you need those two to interact for signaling to be properly modulated and for internalization to occur. So we got from Canada a MC2R MRAP transfected HEK293 cells. And when we gave 10 nanograms per ml of our toxin conjugate, we blew away those cells. And what you see here is in the lower left, the cells that express MC2R MRAP treated with as little as 1 nanogram per ml of our toxin conjugate. And you can see that you get a lot of killing that you don't see in the controls or in the H295 cell line that has very little ACTH receptor. And as a control, if you take an immunotoxin that is bound to transferrin, everybody gets killed. So it's not that the cells, the other cells weren't sensitive to immunotoxin. Everybody has transferrin on their cell first. All cancer cells, they have it by the millions. So it's very easy to internalize transferrin immunotoxin. And that was, so that now is one option that we should develop. And all we have to do is get some funding to do it. Now, so then you can use the ACTH receptor as a target to deliver payloads and deliver toxic payloads. And we've done that. And then the other topic that I want to discover is adrenal incidentalomas that aren't. And I'm sure you're all bedeviled by adrenal incidentalomas and what to do with them. And I'm bedeviled by it. You know, in this world, there's two kinds of people. They're okay to have a benign tumor, and those that can't stand to have a benign tumor. And they don't care that you tell them it's likely benign. They want it out. And when they see a surgeon who says, I can do that laparoscopically as an outpatient, and you go home in the same day, they'll take it out, okay? The problem is that that surgeon then does 1,000 adrenal incidentalomas and thinks that that's how they should do all tumors from the adrenal gland. And that is a serious error. This is an incidentaloma. This is an incidentaloma. This is not an incidentaloma. This is an adrenal tumor, and it should not come out laparoscopically. And the reason it shouldn't come out laparoscopically is this. Half of patients who have a laparoscopic resection, in our data, 21 of 44, will develop widely metastatic tumor all over their abdomen. This makes ovarian cancer that spreads all over the abdomen look tame by comparison. These are 4 different patients. In the red dots, I'm showing you implants in one cross-sectional image of their CT scan. They'll have 200, 300 metastases in their abdomen. Shortly afterwards, they're dead. We can't cure those patients. We currently have an ongoing study that I started myself when I was at the NCI that takes these patients to surgery, opens them up. A surgeon pays 8, 10, 12 hours removing every visible tumor. And at the end of that process, we dump in heated cisplatin, leave them incubating with heated cisplatin for an hour, and then remove the cisplatin. This is called HIPEC for intraperitoneal therapy, heated intraperitoneal therapy. And it seems to work at some level. We're about to publish it. So these are, again, other patients. Look at this patient who had a PET scan, and you see all of these PET positive areas all over the tumor. All of these patients who developed it had had adrenal cortical cancer. Do they do worse when they have carcinomatosis? They absolutely do. Those who recurred after a laparoscopic resection with carcinomatosis recurred earlier and died sooner. It is truly a life sentence because we can't treat them with chemotherapy. And what is remarkable for me is that tumors as large as 20 centimeters were removed by laparoscopic resection. This is crazy. I could see them removing a 3 or 4 centimeter tumor, thinking it was an incidentaloma, and then finding out that it's a cancer. But to deliberately go in and try to remove a 20 centimeter tumor laparoscopically, in my opinion, and if there are any surgeons hearing that do it and have done this, I'm sorry, but in my impression is actually malpractice. So, but why is this happening? what is it about adrenocortical cancer tumors that you remove them laparoscopically and then they end up all over your abdomen? Well, it turns out that adrenocortical cancers have on their surface a lot of a chemokine receptor called CXCR4. And some of you may know CXCR4. It actually came to prominence when the AIDS epidemic broke out. CXCR4 is the co-receptor for internalization of the AIDS virus. Okay, one second. I'm in a room with my dear wife, and that we share our office, and she is Zooming as well. And maybe, can you hear me okay still?
Yes, yeah, no problem.
Okay, good. So this will probably then have less interference from her. So CXCR4 was the co-receptor for AIDS, for the HIV virus, and it got a lot of attention, and drugs were developed for CXCR4 to block it, thinking that that would be a way to prevent the spread of it. And the problem was that these drugs had to be given continuously and so forth. Eventually it disappeared. Well, but there was some crazy guy at the NCI who still was interested in CXCR4. And one day he said, I want to look at all these tumors who see who expresses CXCR4. And he came to show me, and he showed me the slide in the upper right-hand corner of a tissue microarray where the A's were, adrenocortical cancer, were these blazingly hot positive things. And it turned out that the adrenocortical tumors have blazing high levels of CXCR4. Why? I still don't know. But CXCR4 binds to something called CXCL12. It is actually the ligand to which CXCR4 binds. And actually, bone marrow cells, stem cells, have CXCR4 in their surface. And they go home to the bone marrow because the bone marrow is full of CXCL12. And that's how bone marrow stem cells stay bound to the bone marrow. And what we currently have is a drug called plerixafor, which actually binds CXCR4 and prevents CXCL12 from binding. And when we go to harvest stem cells for cancer patients, the night before we're going to do the harvest, we give them plerixafor. The plerixafor goes to the bone marrow, competes with CXCL12 in the bone marrow for binding to the stem cells CXCR4. The CXCR4 no longer binds to CXCL12 in the bone marrow, and they go circulating through the bloodstream. And the next morning, we harvest them as they're circulating. Okay, so we had CXCR4, and it turns out that for reasons I don't understand, the peritoneal surface is full of CXCL12. So you end up with a tumor that's full of CXCR4 on the surface, a peritoneal surface that is asking it to home to it, and that's why you get peritoneal carcinomatosis or peritoneal metastases with adrenocortical cancer. So expression of CXCR4, high in adrenal tumors, high in blood, i.e. in stem cells, much lower across all other cancers. We then did a model where we took peritoneum from the mouse, which also has CXCL12, put in a tumor, in this case, the H295 adrenocortical tumor that has gobs of CXCR4 into the peritoneal cavity, pre-treated with plerixafor or treated with plerixafor, and we were able to prolong the lives of these animals. But plerixafor we can only give once a week. We need a long-acting plerixafor that you can be giving continuously to these patients. So CXCR4 likely, almost certainly has a role in peritoneal carcinomatosis after laparoscopic resection. And don't let a surgeon do laparoscopic resection on something that you have been following and you now think is a cancer and not an adenoma. They can take out all their adenomas, but not their cancers. And by the way, surgeons, as we all know, are really confident people. They're confident that that metastasis that occurs in the brain is everybody else's problems. It's not going to happen to them, okay? The problem is they don't treat adrenocortical cancer. And so they don't realize how bad it can be. And so we need plerixafor or something similar to deal with peritoneal carcinomatosis. So, and by the way, when I was at the NIH, right before we left, we were developing a assay, a clinical assay. And what we had here was plerixafor with copper 64. This is a woman with adrenocortical cancer who had 3 lung metastases. And we injected in her vein plerixafor with copper 64. And look at the localization. Isn't it beautiful? So you can use this to localize adrenocortical cancer. So I'll skip over this here and then just come to the last thing that I wanted to talk about. This is the steroidogenic pathway. You all know these a lot better than I do. You know, as oncologists, we've been cursed with having to memorize the Krebs cycle because there's now 3 cancers that arise from mutations in the enzymes of the Krebs cycle. So I always kid our fellows and said, you know, you learned it in high school and then you forgot it. You learned it again in college and you forgot it. You learned it again in medical school and then you forgot it. And now you got here to fellowship and you have to learn it. You can't forget it because there's 3 enzymes, isocitrate dehydrogenase, fumarate hydratase, and succinate dehydrogenase that cause cancer. So you have to know this, okay? And there's a really interesting drug that is begging for us to try it. And it's a drug that Bristol developed as a kinase inhibitor for RAF kinase. And you know what it did? They stopped its development. Why? Because it killed off the normal adrenal. Unfortunately, back then we didn't have the pandemic and we didn't Zoom. And I was out of the country at a meeting when they had their final board to decide whether or not they would, kill this drug. And they killed it. Why? Because we were killing adrenal glands. I would have told them, I kill adrenal glands all the time with mitotane, and you can just replace it. Nobody needs their adrenal if it's going to cure their tumor. So, but they killed the drug. And what was at it? It was actually being converted in the adrenal to a very toxic intermediate that was then killing off the adrenal gland. And what was needed for this very toxic intermediate? The very enzymes that is present in all adrenal cancers. And this was the pathologic findings. Zona glomerulosa, gone. Zona reticularis, gone. Okay. And what you needed for it was STAR, the enzyme that takes in the drugs or the hormones, and you needed CYP11A1. And you can see in adrenocortical cancers, nearly all of them have this. So it's not just the normal adrenal. In fact, you can see that the normal adrenal here, there's higher levels of STAR and there's higher levels of CYP11A1 or as high in adrenal tumors as in the normal adrenal. And this is a drug that's begging development in adrenocortical cancer. So the conclusions, endocrine tumors are uncommon, but they're fascinating as can be. Targeted therapies in ACC, where we're targeting kinases and other, esoteric thing in tumors have been a major disappointment, and we're not going to get there. But we can develop targeted therapies for ACC at targets that we've known about for 30 years. An ACTH antibody, I hope to be able to develop that, may be useful beyond ACC. If you've got somebody with pituitary Cushing's, it wouldn't be bad if you can't resect it or if it's recurrent and recurrent and recurrent to have an antibody that just binds up all your ACTH. The ACTH receptor as a target is a good one, not only for treating it, but to deliver payloads such as Pseudomonas exotoxin. We should think about plerixafor or really drugs like it to treat or prevent peritoneal implanting and carcinomatosis. And we need to exploit the adrenal cell's unique synthetic capabilities. And that was what I was showing you at the end. So I'll acknowledge my wife, Susan Bates, who actually is responsible for practically all of the sequencing data in adrenocortical cancer. Maureen Angerly was a research nurse I had at the NCI, without whom I couldn't have done all that I've done. Ira Passner was my mentor, and you'd think that I didn't do well with him. It took me 25 years to convince him to put Pseudomonas exotoxin on ACTH. And Lynn Huff was a technician who worked with me for 30 years at the NCI and was just ever so wonderful. And I'm very thankful for all of them. So I'm going to stop sharing. Okay, Alice? There's 5 minutes left if there's any questions.
Thank you so much. I super enjoyed this talk, and I have a lot of questions for you and a lot of potential collaborations, which we'll do offline.
We'll do on a
because,
separate Zoom.
Yes, okay, we'll do a separate Zoom. I want to congratulate you on your intellectual honesty, because a lot of that data on the genetics of the tumors, that was your blood, sweat, and tears, and a lot of years of work. And then to be able to say, this is not the way to go. I had an uncle who was a sort of a famous scientist, and one of his mentees said the best thing he ever taught him is that if you're in a hole, stop digging. And I think that was kind of the message on the mutational analysis
Exactly.
of ACC.
Exactly.
I also wanted to ask you, because you started with a lot of the things that are devastating about ACC, but you also mentioned that a lot of your patients have survived a very long time. So,
Surgery,
and that they all
surgery.
presented with metastatic disease. So can you tell us, what do you think are the therapies?
Surgery.
Aside from maybe they had good luck in their tumors.
Surgery, surgery, and more surgery. So with chemotherapy, I sometimes will downstage them, get rid of some, but it's surgery, surgery, surgery. And before I came to Columbia, I actually, when I interviewed, I said, I only want to interview with surgeons, really. I want to be sure that I'm coming to where there are good surgeons that can do this. And I interviewed with thoracic surgeons because, and then I interviewed with all the interventional radiologists so that they could ablate all these tumors, so they could embolize them. That's how we've made progress. Everybody, I have probably 40 patients or 50 patients that are alive greater than, 10 years. And all of them, I was the traffic cop who got them to a good surgeon. And that was my job.
But you also use mitotane, correct?
Yes. And it's a valuable drug. It really is. It really is very valuable. I always tell patients, it's a marathon. We're going to start easy. We're going to race it gradually. We'll get and whatever we get to that you tolerate, I'm okay with that. Eventually, you'll get to a therapeutic level. It might take you twice as long. It might take you 7 or 8 months to get to therapeutic level. But I'm doing this not for now, not for next month, but for the next 5 years. So I just want to get there. And it really is a good drug. And
I don't see other questions yet, so I'll just ask one more sort of common question. Isn't it true that ACC was one of the first cancers where this cherry picking of oligometastases was in fashion and is still in fashion? Now that's becoming more the rage in other solid tumors.
Yeah, it is. And it's very, I hate to say this, but in 1996, I removed 85 lung metastases from one woman. Okay. 43 from one side and 42 from the other. It was pretty well balanced. She's still alive. She lived long enough to get breast cancer in 2010, and she's cured of that. And it's as time has gone by, I've gotten more and more aggressive, because even those that don't survive, they live longer. And when I'm challenged and they say, well, you have a randomized study to show that? I said, no, but I'll show you some scans of somebody who had no cancer and then all of a sudden presents with these large tumors that appeared over 3 months. And you tell me that they were going to be alive 10 years later if we didn't do surgery. I don't mean to be arrogant. I don't need a randomized study. Right. I've seen this over and over again. All of these people that are alive weren't going to be alive 3 months later, much less 10 years later. So there's some things for which we don't need randomized trials. There's some things for which we do. And so I'm really aggressive about it, because even those that aren't cured, it's obvious we're prolonging their lives. So you just got to have good surgeons. And then you have to convince them that we should be doing this, because, you show up and they've got 20 lung metastases and you say, I want them out. They say, are you out of your mind? You say, no, take them out. I know this will help, So that's what is essential.
I think Dr. Stewart has a question.
Yeah.
Yeah, thanks. Let's see if my microscope. Yeah,
it's on.
Thanks for a pretty sobering talk. I also work on pancreatic neuroendocrine tumors, and the stories are kind of similar. One thing that comes out of that I'm sure you've thought about is all the pathway analysis. So they all have different mutations. Most of them aren't, it's not clear how they're doing, what they're doing, but about half of them feed into PI3 kinase pathways, et cetera. So PTEN mutations, TSC mutations, et cetera, PI3 kinase mutations and others that enable sirolimus, mTOR inhibitors in clinical trials that actually do have some beneficial effects. So you must have done the same kind of thing there. I'm wondering about just RNA profiling and expression analyses, differential gene expression, et cetera.
Yeah, so we did all the RNA profiling. There was nothing that emerged. So, and I take it you work on PI3 kinase or the mTOR pathway and so forth, and you can put that at the center of the universe. Everything eventually, the reason, so you probably don't know this, but everolimus was the most widely prescribed drug for a mutation detected on an analysis. And that's because every gene that is mutated, you can find a way to the mTOR pathway, okay? Or it came from the mTOR pathway. So it's critical.
No pathways
right.
up. I mean,
no pathways came up, correct.
Sure.
I mean, we did, ingenuity and all the standard things and so forth. I actually now, at Columbia, Andrea Califano does some slightly more sophisticated things. Someday I want to convince him to do it for adrenal cortical cancer, but I'm afraid he'll find something and I'll have to do something about it, even though I don't believe it, So I'm trying to decide whether I go down that, whether I start digging that hole, Alice, or I stop digging. So, so mTORs work. But
familial forms. I mean, you mentioned Lynch syndrome. Is that the only example of familial ACC?
Yeah, but it's probably responsible for only like 1 to 2%. But I do think it is, So I think, as I said, Gary Hammer was right on that. Gary Hammer is not right about a lot of things, but he was right about that. So, so it's, and then P53 is clearly, so people who have Li-Fraumeni syndrome, those individuals get ACC universally. I mean, so, and in the cohort of children in Brazil has P53 mutations. So,
and the cytokine receptor story or chemokine receptor story, that didn't pop up in expression analyses?
No, it doesn't. It doesn't. Yeah, because
that would only be metastatic.
Right. I don't know what it's doing there. I will tell you that it's on the glomerulosa and less so on the fasciculata. And if you look at CXCL12 expression, the area surrounding the adrenal gland has a lot of CXCL12. I don't know why that's there and whether it's feeding the glomerulosa, and that's something that is important, and it may well be.
Have you looked at RNA expression in metastases as opposed to primaries, and are there differences?
So there are some differences, but that data has got to come out. So all of our patients were metastatic disease, like I told you. All the, 99% of the ones I had at the NIH, which is when I did this. So I didn't have their primary, and I probably should have been more aggressive about trying to seek out the primary and so forth. But this was actually, all of these were frozen samples, so we had really high quality RNA and everything and so forth. And I just thought, I'm going to get degraded RNA from some primary that was done wherever and stored however. I said, it's not going to be worth it. So we didn't go down that hole, because actually that was when it used to cost $5,000 to sequence one, sample. So, I didn't have another $200,000 in hand. So.
Thank you so much.
Okay, thank you,
I don't see
Alice.
any more questions. Thank you very much for sharing your time.
Thank you, and thank you, everybody.
I will be in touch.
Okay, Alice, you take care. Bye-bye. Bye, everyone. Thank you. Thank you for the invitation, Alice.